What's up, everyone? Jeff Lewis here, Lewis Physical Therapy and Sports Rehab. I want to go over today. It's a conversation we have pretty frequently, given that we see a high volume of high school baseball athletes, mainly pitchers, in our clinic. And that is really what our checklist and criteria is for return to throwing. Now, when we're talking about this here, yes, we will go through some bits and pieces of this when we're having a guy come back after, let's just say, a hamstring strain or a knee injury or whatever that is. But this is predominantly very heavily focused for those coming back from arm injuries. So you're coming back from some type of shoulder injury, labral surgery. You're dealing with an elbow thing. You come back from TJ, or come back from a flexor pronator strain, on the nerve issues. A lot of that there'll be definitely some specifics or some things that are specific to each injury, but for the most part, these are the general rules that we follow. Now, what I will say is, this is especially, a lot of times I see this because I have this happen where people come to me after going through an elbow rehab and their shoulder's not tested. If you're dealing with an elbow, you have to test your shoulder. Just like if you're dealing with the shoulder, you have to test your elbow. So the reason being is because a lot of times what you see is guys come back from elbow injuries or elbow surgeries. In their buildup, they develop some shoulder problems and vice versa. And I think that's just a little bit of, there's probably some type of kind of neurological, not neurological, but maybe more of like, the best way to put it, like unknowing compensation, meaning when you're coming back from an elbow injury or shoulder injury, you're probably going to move a little bit more. Say it's an elbow, you're probably going to end up moving a little bit more through your shoulder naturally as you're getting your elbow accustomed to throwing and whatnot. So we really want to make sure that structure above or below is stronger than it would have to be normally to make sure it can withstand those forces. So jump right into it here. Return to throwing criteria. First things first, you need to make sure you have a normal shoulder and elbow range of motion and clinical exam. So from a shoulder standpoint, we're looking at total range of motion, flexion with the scapula pinned and without it pinned, cross-body adduction. Generally, for total range of motion, you want to make sure there's no difference greater than 5 degrees bilaterally. So we're comparing it to both sides. There's some pretty good research to support that. Cross-body adduction, so coming across this way with the scapula blocked, I want to make sure a guy can at least get to 90. And then shoulder flexion pinned and unpinned, same thing. You don't want to have any differences greater than 5 degrees. Now, if a guy is, 6 or 8 degrees, it doesn't necessarily mean I'm going to not have them start throwing or whatnot. However, I'm probably going to pay a little bit more attention to certain things, whether it's in their prep, their arm care, their recovery. So that's just a lot of stuff to take into consideration. Now, if you're off 15 to 20 degrees, totally different conversation. We're probably not going to get going on throwing, okay? So that is the one thing there. We are comparing bilaterally. Exam-wise, clinical exam, that just means I'm putting them in different positions. Like, I'm going to stress test them. If it's a ligament, I'm going to valgus them down here. I'm going to valgus them up here. If it's a shoulder, I'm going to test their cuff strength manually in this ERIR position up at 90-90 and some different positions as well. So that's just kind of some of the kind of ins and outs that go into what does normal range of motion and exam be. From an elbow standpoint as well, extension versus flexion. We also want to make sure if we do have baseline values on guys, like any guy that I have come into me, we're taking values, and then we're going to keep those values as reference, whether it's for a year, 2 years from now, if they have another injury pop up, we know what their baseline values are. So that's kind of why we go very much off of that more than anything. And then we monitor that throughout the entire process of when they're starting to throw so we can see and identify if there's any changes, maybe once every 2 weeks or whatnot. Shoulder ER to IR ratio greater than 0.67. Almost always guys will be stronger internally compared to externally when they're getting back to throwing, especially if, let's just say it's a guy coming back from labrum surgery. It takes a long time for that external rotation to get back up. So in that case, the minimum after like a Tommy John or whatnot, that I want to see that ratio is a 0.67. Honestly, I prefer it to be able to be higher than that. And there have been times, knowing the individual, where I've kind of held back on throwing for a week or two just to really give them a little heavier dose, maybe some isometrics, eccentrics, or whatever it is, to get that number up, mainly by increasing their external. So that's just, again, that is the minimum before you have a guy start throwing in a post-op case. The other side of this is we want to make sure there's not a greater than 10% asymmetry side to side. So let's say that their ratio on this side is pretty good, but their external rotation strength on their non-throwing side is like 20% stronger than their throwing side. That's a bit of a problem. So we're probably going to still hold off on that, make sure they can get back to their somewhat normative values. And again, this is all just general rules of thumb. Some of it's a little firmer than others, but we have to also take into context the athlete and their profile and how they profile historically. So that's those two things there. Now, tolerance to loading. This specifically means in the gym. Now, what I will say with this is I am not saying I want guys to be back at lifting the same volume load that they were doing before they got hurt. However, they need to show us that they can be able to produce force, control force, and withstand that force, not from during that session, but recovery in terms of push-pull patterns, horizontal push-pull, vertical push-pull, different movements through there. And this is specifically to upper body. If we're dealing with an upper body injury, they're training lower body and core the entire time. But this is specifically, I'll just write here in parentheses, gym. Okay, so there's that. Then the kind of last part here is, before we have a guy start throwing, we want to make sure they can do some type of closed chain or plyo drill. So closed chain just means you're in essentially your hand is in a fixed position. So we'll just say, planks, bear crawls, side planks, planking to like an overhead press, all things like that. Now, if I have a guy that, let's just say, has an ulnar, bony issue, whether it's to come back from a stress fracture, whatever that is, I'm going to be a little bit more cautious on doing it as aggressive closed chain from there. However, if a guy that's come back from its standard Tommy John or lateral surgery, we are going to be doing an absolute ton of closed chain stuff, not only to really facilitate that active terminal extension for guys, but also getting a lot of good stability up at the shoulder from the co-contraction of the rotator cuff. So that's one big piece. Bear crawls, they're in a plank, they're going up and down a step, different directions. So there's, we'll kind of put here, there's going to be straight ahead, side, and maybe even some kind of rotational, and that's going to be more of like going from a high plank into a side plank. So there's a lot of different things like that more than anything. Now, plyos. Plyos, I mean, it's in the sense of medicine ball drill. So 2 hand to 1 hand. So we'll say 2 hand to 1 hand, okay? Now, what I will say is, and I did this earlier on in my career, I would have guys do every single type of plyometric progression under the sun before they go and start throwing. I don't think that is necessary anymore. I think it's more a matter of, again, we need to make sure we are going for the qualities versus every drill under the sun. So we start, and I'll kind of go over here for the plyos. So your extensive versus intensive, okay? And your extensive is going to be like, we'll just say 2 to 3 times like 12 to 15 reps. So these are much more submaximal, focusing good rhythm. You're maybe doing these on the wall. There's really a very low eccentric force and very low concentric force from that. Intensive, you might be closer to like the 3 to 6 times, we'll just say like 4 to 8. These are a lot higher intensity reps. This is a very, very general set and rep scheme prescription or whatnot, but just so you get an idea of kind of the differences between the two. These are historically intensive, are much more higher, CNS output, your more explosive medicine ball type throws. These are going to be more of your kind of more preparatory. So if we weren't talking about from an injury standpoint, this would be what we would use for like a young athlete from a youth development standpoint, or just in a GPP phase, really getting some volume in more than anything. So that's kind of the way that we look at those two. So I would say you are going to have a lot of extensive plyos in different positions. Chest pass, start below 90, chest pass, granny style, side to side, then working into overhead taps, side to side. There's a lot of different variations you can do. Shot puts. And you might not, you're not going to do probably all intensive variations for all of these. Typically, you're only taking plyos for about a month before you get to throwing. You also don't want to just ramp them up too high from plyos, and now we're kind of maybe, we're maybe bleeding into some other qualities you want to focus on, mainly strength and stability at that point in time. And the intensive stuff, that's more a matter of once a guy gets thrown, we kind of slot them into a little more of a traditional S&C program. We're still very much focusing on, not overloading them, but they're probably now moving to, 2 to 3 total body lifts a week. They're doing more higher intensity, CNS work, whether, sprinting, jumping, explosive medicine ball throws, some higher effort strength lifting. They shouldn't be in that kind of GPP or accumulation weights anymore. So that's where the intensive stuff comes in. You do some overloaded eccentric throws, things like that. I just don't think you necessarily need to do all of that before you start throwing. And I used to, I don't think you need to anymore. One hand, that's going to be more of like your plyo ball 1 to 2 hand drills. So you can do some kind of easy trampoline throws, some 90-90 taps. I do a lot of stuff on the side for ER drops, long lever, straight arm drops. I look at this as really more a matter of anything of, I'm really just trying to stress the cuff, yes, ballistically, but from an endurance standpoint more than anything. I just don't think you need to do max effort reverse throws, max effort, plyo or pivot picks, things like that. I think we get a little bit carried away. I think if we get to the point where we're starting to do that in a return to throwing progression, you might as well just have them throw at that point. That's just my kind of thoughts. I know it's not standard or not everyone else's thoughts. That's just kind of what I've seen, how I've kind of, kind of morphed my practice a little bit over the years from that standpoint. So again, that's really from the one-handed plyo, 2 to 1-handed plyo standpoint. I think you need to make sure, like if it's a TJ, you're doing this stuff for a month. If you've only been down for 2 to 3 weeks, I might not even do plyos. I mean, I'll be honest with you. There's times I have guys after, posterior labral, surgery, things like that, where we don't really do much plyos before they start hitting, because to a degree, I think that hitting and throwing itself are going to be plyometric in nature. It's a quick stretch followed by a quick shortening. And I think that we can't lose sight of that, where, there's a lot of times in some cases where I just don't know if a guy's very mobile, elastic and whatnot, and we're really focusing on stability side of things, giving them a medicine ball, having them throw as hard as they can, they're probably just going to feed into the pattern, the issue that they have. So we kind of in some cases, let the sport be the main plyometric activity as well from a throwing standpoint. But again, these are some very, very, while very general, very basic, very important criteria that you need to follow, or your child needs to follow, if you're coming back from an arm injury. So take a look. Again, feel free to kind of go back and watch this, look at certain sections, one or the other. If you're coming back from injury, make sure you're speaking to your provider about these. Do not return to, if you're coming back from Tommy John, do not go back to throwing until your shoulder strength has been assessed. That's a huge, huge piece of this, okay? So again, if you have any questions on this, whether it's just on these items in particular, pertaining to your specific injury, go ahead, leave them below in the comment section, or the questions in the comment section, and like our channel, subscribe for more content like this.